Yeah, now I will invite Dr. Ajay Aurora. He will be speaking about lasers in diabetic retinopathy and DME, and also how to manage the recurrences. Dr.
Thank
Ajay.
you, Dr. Babu. Thank you for including me in this course. And Dr. Babu, Dr. Vishali have been actually guiding in my retina journey. Before I start my presentation, just one or two points which have already been discussed I want to highlight. One is in the study, the SN Dream study, what is most concerning is that in Indian population and what was published in 223, the ICMR data, they analyzed patients of diabetes above 20 years of age. And in India, the people who are affected are less than 40 years. So these people are highly likely to develop diabetic retinopathy, and that is very, very disturbing. And other thing which was pointed out was the South Asian phenotype, which is typical of Indians who are non-obese and yet they are diabetic. So that is also very, very disturbing, but that's the way we are, that's what our genetics is, and that's what I think we should control on. So thank you for the invite, and can I have my slides, please?
Yes.
Yeah, so I'm talking about lasers in diabetic retinopathy and DME, management of recurrences. So Mark Twain, once when he had expired, he was still living, and reports of my death are greatly exaggerated. Lasers too are not dead. They remain relevant in the management of diabetic retinopathy even today. So what my plan of presentation is to talk to you about the standard ATDRS protocol, the modified ATDRS laser, the modified macular grid, plan for focal laser for recurrences, use of subthreshold micropulse laser, and use of lasers beyond the equator for the persistent macular edema and in cases of recurrent vitreous hemorrhages. So the diabetic retinopathy study demonstrated that there was a 50% reduction in the rate of severe visual loss in patients treated with pan-retinal photocoagulation, and prompt laser was necessary in cases of high-risk PDR. ETDRS told us about the relevance of treating the macular edema and also showed us that in cases of severe NPDR, scatter laser could be considered. Aspirin had no role. And this is a slide of 2006 when we were going after the red lesions, when there was a focal hyperfluorescent spot on an angiogram, and we were trying to precisely laser them. We don't any longer do it because they lead to scotomas. We were doing a grid laser for diffuse diabetic macular edema, and then we had a modified grid laser which came up after that. But we were happy treating them and ending up with a flat macula with a paracentral scotoma when these people will have difficulty in reading, but we were happy with it because we did not have options available, which is the pharmacotherapy, but not any longer. So then came up with the drcr.net study and the European expert panel, which clearly said, and Dr. Vishali has pointed out, that center involving diabetic macular edema must be treated with pharmacotherapy, and an extra foveal macular edema with a focal edema should be treated with laser. So this is what we do for the focal edema. And if you have a patient who has an edema which is about more than 500 microns from the macula, which we were treating after this report. But personally, I would follow these patients which are more than 750 microns. So this is another patient who was treated with focal macular edema. So these are the various types of macular grid, the diffuse grid by ETDRS, a modified ETDRS, and the mild macular grid photocoagulation. In the mild macular photocoagulation, the microaneurysm is not directly lasered, while in a modified grid, the microaneurysm is just you turn them into a light gray, and for the focal edema, it is definitely useful. Now, in case you have treated them, how do you treat a recurrent macular edema? So there are certain rules for that which have been said. A persistent or a residual CSME after 3 months, or new residual areas of thickness, you can take the treatment up to 300 microns. That is what was recommended by the ETDRS. And always when you treat, you must do an angiogram. But this is no longer done. I would prefer to be outside 750 microns of the foveal center. And if on the OCT I find a thickness of 450 microns or less, I tend to do personally in my patient a subthreshold micropulse laser. Like for example, this particular patient who had a macular edema which was extrafoveal with a visual acuity of 6.9, we went ahead and treated this patient with a subthreshold micropulse laser, and the patient responded well. Another patient who had an extrafoveal edema before cataract surgery, it's extremely important not to operate them for cataract till you have handled the macular edema. So we treated this patient again with micropulse laser, and subsequently was taken up for cataract surgery. The patient did well. We have other lasers like a Navilas laser where the fovea is protected, the other lesions are marked out, and a laser is done. So by a careful planning, Navilas laser can automatically treat these patients. And the advantages is there's a clear-cut guidance how to treat them. There's a protection of vital structures. The eye tracking is fed in, and there's a digital documentation. We have cases where we have treated, this is a 61-year-old male who is a type 2 diabetic, hemoglobin A1C was 8.6, treated with anti-VEGFs, but was persistent diabetic macular edema. You do a angiogram and you find there's an large area of capillary non-perfusion in the periphery, and we have NBE. So this person is not going to respond. You will keep on injecting anti-VEGF till you start treating them. And once an additional PRP is done for these patients, the patient, so here the laser has been done, and you might have some cystoid changes left, but the patient responds. In cases of panretinal photocoagulation, you must split your sittings into multiple sittings, and if you do excessive laser, you might rarely end up with a choroidal detachment. Now here I'll show you 2-3 cases how laser has helped us in treating cases of recurrent vitreous hemorrhage. So this was a gentleman who went ahead with a vitreous vitrectomy with fluid air exchange, siliconal injection. Subsequently, siliconal removal was done, and patient had a recurrent vitreous hemorrhage. We waited for some time, gave an intravitreal anti-VEGF, and then again, patient had a repeat bleed. Patient was taken for the vitreous lavage, fluid gas exchange was done. And at that stage, after the fluid gas exchange, we did a wide field angiogram. And we found that in the periphery, it was not completely lasered. We had done just beyond up to equator. There were areas of NV, there were large areas of capillary non-perfusion. These areas were subsequently treated well. And for now we have waited for almost 21 months. Patient has not had any fresh vitreous hemorrhage. His other eye, which was treated, we had done an angiogram before the vitrectomy, treated these peripheral areas, and patient did well. So there's multiple other patients where if in such a case with so much of laser, I would not expect any more NV, but yes, there were NV and patient was having small recurrent vitreous hemorrhage. We treated this and patient responded well. If I did not have a wide field angiogram, I would not be able to detect them. So that is probably the utility of wide field angiography. The same patient in the other eye, we found large areas of capillary non-perfusion and patient did well. So this is, I've had a few interesting cases. This is one of them who is, whom I have told about subthreshold micropulse laser. So I have treated his macula with a 5% duty cycle micropulse laser and the periphery with the micropulse PRP with a 10% duty cycle. I have a 3-year follow-up on this patient now. He has had multiple sittings, over about 3 sessions of micropulse PRP in last 3 years. He's maintaining his fields. Whenever he gets a small NV, we treat them with a normal laser, but the other areas we treat them with micropulse, and we are able to maintain. So this could be an option. I'm in practice, so I can't do an institutional study, but that should be an option. So the take-home message for diabetic macular edema is I would treat a patient with laser when it is beyond 750 microns. So the laser photocoagulation was relegated to the backyard with the advent of pharmacotherapy now, but with a better understanding, it's making a comeback. Panretinal photocoagulation remains the cornerstone of PDR treatment over last 4 decades and still is relevant. ultra-wide field angiography has helped us in identifying NV and CNP areas, and this could be an answer for the recurrent vitreous hemorrhages. Laser photocoagulation is the best way to treat focal extramacular edema, and subthreshold micropulse laser used judiciously may be an effective way to treat diabetic macular edema and probably reduce the load of pharmacotherapy. Thank you.
Thank you very much. You are on time. Very good. So we now move to the lasers because many youngsters only very comfortable with injections. But believe me, diabetic macular edema is a chronic disease, and certain times injections may not be the answer for a long-term basis. So there are certain subsections of diabetic macular edema and PDR, obviously. Laser plays a major role. In this, you have covered very well about the lasers, where exactly you need to do all the areas and when to select laser. Definitely, we will not do the center involving diabetic macular edema. You consider injections apart from systemic control. However, there are indications. If you see there are leaking areas are there, okay, with diabetic macular edema, where the majority of the leaking areas are between 300 to 500 microns. What is the strategy you will apply?
So I have two strategies, sir. In case there is an associated macular edema on the OCT, I would probably go for the pharmacotherapy.
It is there. It is
If it is, because I now no longer go closer to 500 microns, so I would rather give an intravitreal anti-VEGF
Why would you?
And if the thickness has come down to 450 microns, I have a micropulse laser available, and if it is a diffuse diabetic macular edema, then I would give my micropulse laser. If it is a focal lesion, a single microorganism or 1 or 2 microorganisms which I can handle, then I'll take a 50 micron spot and probably treat them without making a very, very gentle gray lesion.
Yeah. You need to be very, very careful in doing laser in the near to the macular center, between 300 to 500, even beyond also. I would be very, very careful in that, because what we have observed is over 5 to 10 years, the spot you have given spreads, and the scotoma can be certain times disturbing. So that's why committing for a laser, what you have done a small spot today can be enlarged and it can become a bigger spot. That's what makes you hesitant
these patients
about.
must have a good metabolic control.
Yeah, obviously.
That's always very important.
No, that we have already covered, and we will say that good systemic control, injections you have given, but still 1 or 2 leaking areas which are prominent, but it is between 300 and 500. Certain times that alerts you, and it will scare you also to do the laser, so you need to be careful in that. And another important aspect is only don't go for macular edema by repeated injections. There is a peripheral CNP areas. This is very nice point which he has highlighted, that by treating them, you can reduce the recurrent diabetic macular edema, which is very, very good. And excess laser, what would you suggest for all the delegates, that how to tackle that you will not do a excess laser, so that the complications will be much more, even a deep laser or excess laser? Both the things can lead to complications. So what are your suggestions?
So there are very defined way which have been said as to how do we space our spots, what should be the lesion color when we give. If it is white color, it means it's almost involving the entire retina. So it should be a gentle gray color. Initially, we spread out depending upon the, Dr. Vaishali asked a very important question when Dr. Babu was presenting, that how do you assess clinically? Do you sit down and count those 20 hemorrhages? Similarly, I think we are able to assess what is the severity of the disease. So sometimes we might space them 1 burn apart or maybe half a burn apart. We do not go closer than that. And sometimes later on, patient comes back to us. So I personally, for myself, on a diabetic patient follow-up, if the patient comes back to me after a year, I would repeat an angiogram in these patients because I may miss neovascularization. So I tell them that once a year, if you are stable, I would like to do a fluorescent angiography. Since I have wide field, I do it now, and then I laser them. Sometimes you have to augment our PRP once we do an angiogram. So this augmentation, you call it a fill-in PRP, and we do it whenever it is required.
Rather than saying once a year, I would say that if there are any alarming developments in the on examination, then probably we will commit for angiography
Yes, sir.
rather than saying once a year. With this, thank